My name has not changed since yesterday, and where I work, I still work. So for introduction, pre-anesthetic assessment or pre-operative assessment is a very integral part of the practice of anesthesia and safe surgery, and I'm careful not to just say anesthesia because some of these patients may not have anesthesia administered by an anesthesiologist. In other words, even patients who are coming for locals or the so-called minor or daycare surgery also require pre-anesthetic assessment. Okay, it is a period. The period in anesthetist, surgeon, and nurse ensure that the patient arrive in the hospital and theater properly prepared for anesthesia and surgery. During this same period, the patient builds up trust, and everything will go well with him. And that he would go back to the normal state of consciousness and well-being with minimal or no pain. And that is one of the cardinal functions of a pre-operative or pre-anesthetic clinic. The development of rapport, trust. I'm seeing the people who are going to work on me, and that is why for those of us who work in big hospitals where we have a clinic, one of the difficulties we have is when somebody else is assessing at a clinic and somebody else is coming to anesthetize. So for all the lists I do, my resident knows that it is mandatory that the day before surgery, although these patients are declared at the clinic, every single one of those patients will be seen by members of the team, or at least a member of the team that's anesthetizer. If none of my residents sees those patients on the morning of the surgery, they are not allowed to enter my theater. It's just as simple as that. I will go review the patient myself and anesthetize of my own. And that is because it is not just because you are assessing, it is because you are building a rapport, you are building a trust. The patient's hemodynamics and physiological changes, even intraoperative, has a lot to do with the level of anxiety that they enter into theater with. We have had to cancel patients because their blood pressure will not be controlled just before surgery, but back to what, and a day before their blood pressure was beautifully 120 or 70. Why? They were very, very anxious. All right, so it is important to take that up, to build a rapport with the patient and then reassure them. Reassuring them does not mean that you're going to lie to them that everything will be well, when you know that it's not going to be well. Yeah, I mean, in the ICU we do a lot of family conferencing. Actually, within 24 hours, maximum 48 hours of admission of anybody into ICU, and it doesn't matter who you are, whether you're a pauper and you have no money, or whether you are the richest guy in town, we will organize a family conference. The only reason we may not have organized a family conference in more than 48 hours is if we can't find any family to conference with. So that sometimes we don't find any family. They come and dump them and they run away, especially when they hear how much each day costs. But the family conference we do, a lot of people, a lot of Ghanaians are used to doctors talking to them, sitting, chatting with them, without preparing to either scare to them or lie to them. So the problem is that when we tell them we're going to have a family conference, they think we're coming to give them bad news. By the time they leave a family conference, which usually do not last less than 30 minutes, and sometimes can last as much as 1.5 hours, depending on the issues that need to be discussed, they're like, you do this in Ghana? Because they watch it in TV. They think that nobody takes time to talk to them. Because we give them the opportunity, we tell them as it is. And then we give them the opportunity to talk to us, ask us questions. We tell them what the hierarchy, who they can talk to. We tell them we don't want you just doing here and say from anybody, any there. If you have anything, even if you have a complaint, these are the people you can talk to. The person looking after your relative, if the person that hasn't got the answer, nurse in charge. If not, there's always a doctor in the ICU. So by the time they walk away, there's a different relationship built. And that's what we try to do at the pre-anesthetic clinic. Unfortunately, it's usually not as good as what we do in the ICU because it's a clinic. There are many. So the doctors just like a new OPD. Sometimes have to rush things a little bit, but ideally, it should give the patient a lot more. Assessment has been shown to reduce the mortality, morbidity, and to cut the cost for both patient and hospital. Also, because the patients are well prepared, there is an increase in the number of same-day admissions, and same-day admissions are not only for day cases. A lot of the cases we are admitting 3 days before surgery, just because major surgery, there's no need to come to hospital 3 days. If you go to our hospitals, we do nothing for them apart from let them lie on bed. For majority of them, just because we want to see them. Admit them 3 days before. The reason we give is so that we can sort out any problem, and half of the time we're not even monitoring them. So what problem are we sorting out? So in other places, I mean, we do major meeting the patient on the day of surgery. Why? Because we have preoperatively assessed them, giving them a plan up to the day they are coming on admission. But it also means that you need to have an understanding population, or choose a population that you can do that with. Because, of course, for some people, as we get sometimes with the pediatric age group, even when you tell the mothers that, okay, just 4 hours before, do not give any breast milk. They come, when you are ready to take the child in. Have you given anything? Mama no for. Hey, I didn't see. I can't tell you, man, hey. I say, oh, no, soon. The baby was crying, and for any mother, a crying baby has to be fed. So the fact that you said, after 4 hours to the time you are coming for the child, don't give anything else apart from maybe just water. And the baby was crying and wailing. She looked around and so everybody was looking at her child. And the people may be thinking that what a bad mother she is. So she put the baby to breast. All right. So, yes, as I said, it has increased the number of same-day admission, leading to the reduction in cost of stay, both for patient and for hospital. There's a cancellation of cases due to suboptimal preparation of patients, because if you have seen this patient, know what the problems are, we tend to prepare them a bit better than if we do not know about them. There's also reduction in complications that are associated with length of hospitalization. Remember this, when you admit any patient to hospital, it doesn't matter how fit you are, you start counting the number of days of hospitalization. We have said that any patient who is immobilized or hospitalized for more than 3 days, we have increased the risk of venous thromboembolism. Now, if you have admitted a patient who is going to have a major surgery and who will therefore probably stay in hospital for another 1 to 2 weeks, or even let's say for another 5 days, and you admit the person 3 days before, by the day you're having the surgery, you have already probably built up the risk for VTE. And therefore, you in your mind, you say that, oh, the patient was ambulant, so you were not counting it. You probably would not ask them to wear any elastography stocking or use a limited pneumatic compressive device. Why? Because you say what? They are ambulatory. But nobody who is on hospital walks about. And we all know it. When we are in hospital, we lie on our bed. We only get up when we are going to see our relatives who have come to visit us. Or when we have to go and then a little bit, which is just a few minutes probably in the day. For most of the rest of the day, the person is lying on the bed, building up thrombus in the big veins. And of course, for other things that are also related to length of hospitalization, such as hospital-acquired infections, including malaria. So we brag that we bring you to Kolebu to cure you of all illness, and that's you malaria. So what are the aims, objectives of preoperative assessment? These are summarized what was obtaining patient medical information and consultation and lab investigations that are necessary to assess their risk. So preoperative involvement of the anesthesiologist and other relevant players reduces unnecessary routine tests. You'll be surprised how many labs we request for, and the first time anybody is looking at it is when we are doing briefing in theater. Then they say, oh, okay, so patient is fine, laboratory investigations done, hemoglobin. Oh, where's the hemoglobin? You requested that because you wanted to see it before surgery so that you could use it in your planning, in intervention. But the first time the guy is looking at it is when the patient is lying on the bed for the usual timeouts. Optimizing patient condition and developing an appropriate plan for perioperative care and anesthetic technique. So our preoperative assessment is important for us to be able to optimize the condition of patients who come with comorbidities, and there are a lot of those patients. Actually, before we used to look at just patients who are beyond the age of 60 to be very worried about comorbidities such as hypertension, diabetes, such as the ischemic heart diseases, and other complications that are so associated. But now we are looking at it even at 30 years old. Why? Because we are running a race against time to chase for money in our country, where even the young ones are working in the bank and sitting behind us, cracking numbers for 18 to 20 hours a day. And what are they doing? They are doing fast food. So even 30, 35-year-olds are coming to our theaters now with extremely difficult to control hypertension and diabetes. Things that we usually would have been looking out for in the elderly. So if you're using age as your reason for looking out for that, then you may actually be in trouble. Because if you did not do a preoperative assessment, my closest friend has been hypertensive for almost 15 years now. I am not that old, I'm still very young. And he's been chewing the tablets, at least different tablets, for that long. And he's a bank executive. So if he was coming on my table, he's one of the fittest looking young men. But his senior brother, at a few years older than what he is now, died from ischemic heart disease. Also an executive of a telecom. So there are younger people now which would have taken for granted as the so-called young and fit, and probably not bothered thinking that they are at risk for any intervention, surgical and anesthetic. But now that gives us the opportunity to actually assess their risk and optimize their medical condition, and if we need to, develop an appropriate plan for their perioperative care and anesthetic technique. The third is to determine and minimize the risk factors for anesthesia, and there are many of them. There are some anesthetic you cannot give to certain patients. There are patients that if you give GA, you can just as well dash them the anesthetic machine to carry home because they will not come off it. So, educating the patient on different types of anesthesia care, post-operative care, including management of anxiety, pain, and achievement of all these main objectives, can be coordinated at a centralized place, at a preoperative assessment unit, or as some will call it, an anesthetic clinic, or whatever the assessment takes place. So an anesthetic or preoperative anesthetic unit is not just a room that has designated anesthesia clinic, but for some patients it is their bedside. So whatever you do it, that is actually what you're doing at that point in time. So we take that opportunity to tell the patient, for example, when I'm going to do a transsphenoidal, that patient is going to wake up with the nose blocked because we pack the nose. We do the surgery transnasally and transethmoidal. But if I don't have the opportunity, and you will be surprised, the surgeons always forget that they are busy in telling the surgeons how big the patient, how big the tumor in their brain is, and the fact that if they remove that tumor, their eyesight should get better, and they know how to do it very well. So don't worry, we'll do it very, very cost. So they'll tell them all that. Then the patient gets to us. Then we ask them, what are they going to do for you? They say they are going to open my brain. I say, no, we're not going to open your brain. I say, doctor, but the tumor is in my brain. I say, yeah, but we're going to pass through your nostril. I say, how? Do that big thing. The surgeon showed it to me. He says it's like a big nut sitting at this, and how are you going to pass through my nose and remove it? So that gives us an opportunity to educate the patient. Some of these patients, when you do not do that, wake up with their nose blocked, and they've not been told to breathe through their mouth. So they are struggling, they are fighting with everybody because they think that their nose is congested. They are so very uncomfortable. But we would have told them preoperatively that we're going to block your nose, that when you wake up, you can breathe through your mouth. When they wake up, they will still struggle with you a bit, but when you start reiterating it, they remember that you spoke to them about that preoperatively, and they're a lot more cooperative. If not, their blood pressure is going to skyrocket. Their heart rate is going to go into the skies. Okay. Medical consultation and treatment, as well as lab investigations, are sorted out during the assessment period, as earlier mentioned. One cardinal example I used to use was when one of my major lists used to be major orthopedic and joints surgery. So I used to do most of the hip and knee replacements in Kolebu, anesthetic for that. And my surgeon was Oklu, Oklu. And at that time, people was probably the only guy, apart from the focus guys when they come around, who most people could trust to do their hip or their knee. The rest were now in the learning curve. So what it meant was we were getting all manner of people with crazy comorbidities, but who were rich and who had decided, okay, I don't want to fly to South Africa or Europe, because they said there's this young guy here who can sort out your knee or your hip within 2 hours, and then you'll be fine with it. So I'll be there, you call me Chris. We have another one. This one is from Nigeria. They'll come, COPD, all manner of things. So after the first few, and Okra and I have been friends for years. You know the funny thing he does? When he gets the case, he sees the case, then he calls me and says, Chris, we have this case, I'm sending the case to you. Then he reminds me, post-operative management is solely your responsibility. He tells me, I will do the beautiful surgery. Whatever happens post-op is your wahala. So, I bite the bullets. We were going on and on, but it meant that actually a very young boy, because I was much younger then, I was stressing myself. I actually had to be thinking about the physiology of everything. I'll be at my house, then 10 p.m., the nurses don't call him, it's his ward. But when there's a problem, even if they make a mistake, I call him, I have to call the tool. And they'll call me, hey, don't do it. So I called the pool and said, okay, you know what? We need to solve this problem. He said, how do we solve it? I said, it's supposed to be a triangle, not some bisected line somewhere. We need a third person team. He said, who are you thinking? I said, Alberta Palu. What did we do? We decided that any one of those patients with comorbidities who were going to come, immediately referred them to their surgery cancelled until further notice. I referred to Akbalu. He sorts out the preoperative comorbid conditions and stabilize the patient. Sometimes it takes us a month or even 6 weeks. It is only when he's happy with the stability of that, then he writes another referral back to me. Well, that is okay, this sorted out, this is as far as we can go with it. Are you still happy for us to go on with it? Then I'll now review, and now this is then when I now do my pre-op anesthetic assessment. Then if I'm happy with everything, then I take a clue All right, we're going to go ahead. Post-op, there are two of us looking after it, myself and Albert. Okay, so he's a very good physician, but there were even cases where he looks at it and says, okay, Charlie, we need an extra person. I said, what are you talking about? He said, we need a cardiologist. The man's heart is not good. So we speak to any of the cardiologists, Doko, Edward Ade, Taco, any of them. And then we let them sort out if we need them to go and do anything else, any intervention. We'll sort that all out. What that meant was that patients were spending longer after surgery. The outcomes were more beautiful. In a short period of time, everybody was hearing of us. Oh, yes, they do it. A 79-year-old woman came with bilateral knee. She said we should do both knee at the same time. I said, madam, take your time. She had hypertension, diabetes. Why? Because she heard that 2 weeks before we did a 72-year-old bilateral knee. But there's the moral of the story is basically that we could only do that because we knew what we were expecting in theater. We maximized these patients, and then when we thought that we needed extra consultation, we could send the patient to them. So in just a nutshell for that introductory part, the work of pre-anesthetic or pre-operative assessment is to evaluate patient health, optimize it, anticipate complications, and plan to avoid it or manage it. Okay? So the process of assessment and preparation can start with a health status questionnaire, and in a lot of hospitals outside, and including in our place, we have a questionnaire. Okay? So patient at the anesthetic clinic or given to patient at surgical clinic. They are then filled and returned to the anesthetic department, or the patient could attend pre-anesthesia clinic, or the anesthetic surgeon or nurse will assess the patient on the ward. So we have a generic questionnaire. That generic questionnaire covers basically over 80% of what we want to know from any patient that we're going to anesthetize, irrespective of whether it is an ingrowing toenail or it is going to do a craniotomy for the patient. But then that, as I said, is the baseline. If there are other things we want to assess, we actually have about 2 or 3 empty pages that you can actually fill up. Whenever the patient must be seen, anesthesia and surgery. Anesthesia clinics are relatively recent, as I said, but they are now integral part of practicing safe anesthesia and safe surgery. A lot of what WHO has been preaching in the last few years is how to make surgery as safe as possible. It is at this clinic that assessment are achieved. But what are the principles of assessment? Let's look at them. The pre-anesthetic assessment should be carried out by the anesthetists who would anesthetize the patients. And that's why I said that even when you have a clinic team, okay, that is assessing everybody, the anesthetist who is going to anesthetize should still see the patient before coming to theater. If that is not possible, information of things such anesthetist before the patient gets to theater. For most of the neurosurgical patients, one of my cardinal places neurosurgery, I had neuroanesthesia. So if the people who are in the clinic are looking at the patient who is coming for craniotomy or transphenoidal, and then they have problems, or they have even sorted out the problem, but they think that this one, somebody needs to know, they'll call us and let us know that, oh, you guys, you're expecting in the next couple of weeks a patient with a cardiac issue, dyskinesia, ejection fraction as low as this and all that. Is there any extra thing you would want us to do? Because there may be protocols that we would suggest some of these patients to that they are not aware of. The pre-anesthetic assessment should be done at an appropriate time before surgery. And this is important because people have asked, why can't you just do it before just before going to surgery? Before. It should be done long enough to allow an optimization if there are problems. One of the problems we've had is sometimes junior members of the team in our clinic seeing a patient and clearing the patient, only for you to get to the day before surgery, you go to see the patient in the ward and realize that the patient has 5 major problems that were not addressed in the clinic. And that you know that you cannot address within 24 hours. Now, if you are basically boxed into a corner because the surgeon will tell you, but the patient went to your clinic. But now you know that you are running a risk with the patient's life. So now you are playing games with your emotion. Should I just take it like that? And sometimes it can actually become that difficult because you know that going in means risk at the patient. Not going in means the patient is going to come back maybe 6 months or a year's time because the booking is probably 6 months long. So anybody who misses his may actually be going to the back of the queue. It does not necessarily mean if you miss yours, you go and call somebody in the next week's queue. The pre-anesthetic assessment should be done in a time before surgery to allow time for adequate preparation of the patient. This underscores the importance of seeing patients for day surgery before the scheduled date at the clinic. So for day cases, what they normally would do is that the nurses, specialized nurses, can do the pre-operative assessment with a questionnaire, maybe a week or 2 weeks before the surgery, so that if there's anybody who has a problem, they can refer them to the anesthesiologist to sort out. So pre-operative admission may be necessary in patients who are coming for major surgery or in patients who are critically ill. So if you realize that this is a patient who you need to admit because your optimization cannot be done in an OPD basis, then you can decide, okay, I need to admit this patient 2 days, 3 days, 4 days before for better monitoring, controlling of the blood pressure and sugar and things like that. Okay. So, all patients who would need in-hospital monitoring or optimization, example, type 2 diabetes, which is very poorly controlled for major surgery. The assessment is conducted at a personal interview in the ward, theater, or clinic, or by using questionnaires assisted by trained nursing or paramedic staff. But it must be supervised by a physician anesthesiologist or surgeon. Okay. The pre-anesthetic management of these patients may involve other medical specialties, as I've said earlier on. So do not hesitate to involve them. And I speak to my physicians very frequently, depending on whose input would help in improving the outcome of my patient. So do not hesitate to involve them, but only the anesthetist declares a patient fit for anesthesia. Full stop. We get this frequently. Patient has cardiac issues, so we refer them to the cardiologist for assessment and then optimization. And then when they finish, they write a letter to us. Okay, this and sorted out. So the patient is fit for anesthesia. And we write them a love letter back and remind them that you are not an anesthesiologist, so don't please repeat that again. And we do not apologize for that because irrespective of what the person's pre-operative condition is, the person does not know what anesthetic technique or drugs you're going to use. So it is preposterous to actually talk about fitness for anesthesia. You can talk about the patient's level of optimization, but don't make the mistake of thinking that a physician, actually I would actually prefer a surgeon telling me that the patient is fit for anesthesia because the surgeon is in theater, may have been in theater frequently and would have known quite a lot of what the anesthesiologist knows. But a lot of those who are not in the perioperative area may not be aware of what happens when you give somebody thiopentone and then the blood pressure crashes. Some of it can be quite scary. So every patient who is fit for surgery, as I said earlier on, is fit for anesthesia. In the case of emergency surgeries, and that is a sticking point, because the person has very bad heart, diabetic, the sugar is, he comes with a ruptured uterus or a ruptured ectopic. And so what are you going to do? Are you going to say, oh, because of... So for, in the case of surgery, where early consultation is not always possible, the anesthesiologist who is still responsible for the pre-anesthetic assessment may have to go ahead in spite of increased anesthetic risk but higher potential benefit of surgery. So this is where you do a weighing of risk and benefit. And in medicine, a lot of what we do is actually a weighing of risk and benefit. Every single medication we give to any of our patients, including oxygen, has side effects and complications. But it is because we think that the benefit outweighs the risk that we do that. But it is important to document the effects or what this risk and benefits are. Because when anything happens to the patient, what everybody is seeing is the risk. If you have not documented why you had to go ahead, everybody is asking you, didn't you see the sugar? Didn't you know that this is a man who has a heart as bad as this? But they forget that the person has bled 4 liters. So if you have to do a balancing of risk and benefit, always remember to document it very clearly in the patient. Diagnosis and assessment of severity of disease. So we usually go through a history, which must be thorough to provide information to identify diseases that would affect perioperative outcome. History should include the medical condition or medical problems, assess the degree of the control. So it's not just that they are hypertensive and diabetic. What type of diabetic is it? Is it type 1 or type 2? How well controlled is it based on what is the absolute numbers? What is the glycated hemoglobin level? How many medications is the person using to control it? And that's the beautiful one. So I get my resident tell me that the patient is very well controlled hypertensive. So I asked them what's the blood pressure. They said, oh, the blood pressure is now 135 on 80. I said, beautiful. I asked them, how many medication is the person on and what doses? And you realize the person is on 4 medications at maximal doses. So yes, the blood pressure is controlled at the moment, but you have a very bad hypertensive in your hand. Because if you have to take out one of those, which we do perioperatively, because after surgery they're not going to eat immediately. So some of those antihypertensive may not come in. Some others like like Sinopril and we don't even give it around that time. Then you see unmasking of the severity of your hypertension. So I just tell them, be mindful that the control of any medical condition is not only on the absolute numbers. It's also dependent on what you're using to control and what are the expected end or target organ complications of that condition. What kind of medications are they on and how does it interact with others? And when we talk about that, we mean including substances such as alcohol and then tobacco. Allergies and how does this allergies manifest? Previous anesthetic and history of anesthesia complications. So the person tells you, I've had 3 surgeries. Every one of them I had difficulty waking up. Then in your mind, you know that, okay, I already have a patient who doesn't treat anesthesia very beautifully. History may be obtained from the patient, family, friends, but make sure that the history you are getting is reliable. The system review should be of those relevant to anesthesia and surgery. So although we would have listed all the system, you do not need to write everything as if you are a medical student who is clerking for the first time. Because if you write too much of irrelevant, the relevant items are buried in it, and now it becomes difficult for anybody to see them. Physical examination usually of the cardiorespiratory system, including the airway, whenever necessary and according to the patient's physical status and anesthetic technique chosen. You may need to do the renal, the central nervous system, hepatic system, also examined. Lab and radiological investigation should not be routine. They should be done to complement information that you have already obtained. So if you have good enough information from your history that does not require some labs, there's no point in doing them. One of the things Professor Mrs. Amponsa taught me was that there is nothing known as routine investigation. Even hemoglobin, you must have a reason for doing it. Okay. Routine exam in our setting includes circulating status and urine array, but we call it routine because it already has routine in its name. not because everybody gets RE done, okay? Investigations, but in our setting, we now insist that everybody should get a sickle status done, purely because of who we are. We have a very huge population, sickle cell, and a good number of them do not know until a doctor tells them they are. Okay. Investigations may not be necessary for healthy patients going for invasive procedures. So these are just some of them. Some of these numbers have changed now. So for chest X-ray, which we used to say for those who are above 60, now if you're above 50, you definitely do a chest X-ray. ECG, which we used to say if you're above 50, now we have dropped that to 40. Because we are having people who have hypertensive heart disease even at 35, 38. So other things so if the person has cardiovascular disease, diabetes, renal disease, you definitely get an ECG done. If you have significant respiratory disease or cardiovascular disease, you definitely get a chest X-ray done. Full blood count would be mandatory for everybody who is above 60. But if you're coming for major surgery, you have clinical anemia or hematologic disease, or you've been on chemotherapy, or for a procedure where we expect you to lose at least 10 to 50% of your blood, you would have the full blood count done. If not, you may just do an HP. Renal profile, again, and for those ones that have put 60 there, most of those will drop them to 50. Although our population is aging, but we're also becoming more ill with respect to systemic conditions. Okay, all right. So coagulation profile should be indicated. If you're doing fasting blood sugar or random blood sugar, there should be an indication. So what I've done here is, as I give the conditions, the investigations, then some of the things that should precipitate you requesting for it. So if you have somebody with coagulation who has a hematological disease, even if it's well controlled, or liver disease, or cancer surgery, you would be well advised to do a coagulation profile. Okay. And of course, for every morbid obese person or person on alcohol or malnourished, a liver function test is mandatory. So let's look at risk assessment. The patient's preoperative condition, the complexity of the surgery, the urgency of surgery, the surgical skill, the anesthesia factors are things that contribute the level of risk of patients who come in to have surgery. So this will determine outcome of anesthesia and surgery. So in anesthesia, most of the time you will see us talk about the ASA classification. That is the American Society of Anesthesiologists classification, physical status classification. But now we're moving on to adding other risk assessment, because although ASA classification is quite helpful, there are still people who fall through the cracks. So multidisciplinary management, subspecialty referral, and medical record retrieval are made helpful in the overall assessment of the level of risk of the patient. The ASA classification of the physical status is assessed by using the ASA classification, which grades the patient from P1 to P5 in worsening order. P1 is a healthy patient, totally healthy, normal patient. P2 is a healthy patient with mild systemic condition, which is basically well controlled. In other words, no problem. P3 is a patient with severe systemic condition, and this systemic condition is not a threat to life. P4 we say is a patient systemic condition which is a constant threat to life. P5 we say is a moribund patient who will not survive 24 hours without surgery. By the time I joined anesthesia, I used to be who will not survive 24 hours with or without surgery. And that was one of the most sticking points. Because the classification, this classification was just changed, that P5 was just changed a few years ago. Because the anesthesiologists were always fighting that if it is P5, I will not anesthetize. You have said categorically that this patient will not survive 24 hours with or without surgery. So why am I going to give the person surgery and kill the person if he's not expected to survive? But we realize that yes, some of them will survive if you give them surgery, but they will not survive without surgery. The chance of survival may be low, and there was one cardinal case, my boss said, the chance is probably less than 10%, but the chance of surviving without a surgery is 0. So that's why it was changed. But it was changed so that you now need to actually discuss what is the import of doing surgery in this patient. Okay? PCs are patients who are brain dead, who we are not going to do surgery because they will survive, but we are doing surgery to harvest organs. So when we say a patient is PCs, we are taking them to retrieval theater to harvest some of their beautiful organs for other people. Usually we'll leave an emergency and leave it as it is if it's an elective. And adding an E means that the risk is even higher because we may not have had time to optimize them. So when I say that ASA 3E, it means this is a patient with a severe systemic condition, which is not a threat to life, who is coming for an emergency surgery. Now, there's also a surgical classification of patients, and it's done according to the extension and complexity of the procedure, and that does the S's. So S1, minor surgery, minimal or ambulatory anesthesia usually, or local anesthetic. S2, major simple surgery performed on one organ or system without any other procedure. S3, major complex surgery performed on one organ or system with other procedures or procedures related to the scheduled one. Potential bleeding plus other surgical problems that can be solved. S4 is a major multiple surgery on several organ systems. Post-operative bleeding complications may complicate it and would need special preparation. S5 are usual rescue surgeries with the patient at danger of death. For example, a ruptured uterus or a ruptured aortic aneurysm. These are rescue surgeries. Okay, so the higher the S level, the higher. Then of course we have an anesthetic classification, which is not the A, the A, which is a type of anesthesia based on the type of none at all. So there are some patients who say monitored anesthetic care. So the surgeon is doing their own thing, but we just put a pulse oximeter or ECG just to monitor the patient, but we're not really anesthetizing the patient. So with or without sedation and analgesia. Okay. A2, anesthesia with basic monitoring, vascular invasion, using non-anesthetic drugs or using coadjuvant or supplementary drugs. A3, basically so basic with special monitoring. There is vascular invasion for the monitoring of these patients to monitor hemodynamics and then give them fluids. S4, similar to A3, A4, similar to A3, but here the anesthesia is going to last more than 2 hours. And sometimes we may have to put more advanced monitoring like a pulmonary artery catheter, the so-called Schwann's. It's an anesthetic method limited in its option. So there are 5 minutes, okay. So A5 are some of those patients when we get, then we start looking for who anesthetize. We know that every type of anesthesia we do, you will be beaten. You are damned if you do, you are damned if you don't. But so they are limited because of the critical state of the patient. It does not mean that the patient cannot be anesthetized. So when we get pregnant women in heart failure, secondary to let's say an aortic stenosis or a mitral stenosis, who has been a known cardiac patient who has squandered when they told her not to get pregnant, we know that we are damned if we do. We are damned if we don't. Now, so what we do nowadays is actually to combine these 3 classifications. So a PSA classification. So in other words, if you have a B5, S5, A5 patient on your table, you should go and visit your pastor or your imam before you come to theater. Or make sure if you don't have a back door through the theater, you let them build one. Because that can be Astros. That's the highest risk you can have. A patient with 555. Combining these classifications predicts the preoperative risk better than using just the ASA classification. And now we think that it's probably the better thing to do. Then you can actually plan your anesthetic intervention and the surgical intervention. So sometimes I can tell a surgeon that no, you're going to stage this surgery based on this patient high risk. So you just do remove the tumor, it's plenty. You remove half today, let's bleed small. I was actually telling one of my neurosurgeons just before coming. And this case, tumor frontal, tumor parietal. I told them plus my residents that take one out and come out. They took one out and then the patient was doing well, so they were dancing. Then they went after the second one. And now I'm struggling in ICU to get the patient better. I looked at him and said, you, one of these days I will hit you with something. But sometimes that is actually, the surgeon may not understand it because he's seeing the surgical ease of taking that out. But what is the implication post-operative patients? Social and economic factors in our environment have come to complicate the PSA classification. One of the worst risks that you can have is poverty. To the extent that I am writing a report to my chief executive at the moment about patients I'm admitting in the ICU who can be saved and who are basically exhausting my salary and still dying because the hospital is not giving us access to funds. But social and economic factors or financial constraints may also have risk factors. The anesthetist must consider and balance judgment with regards to the risk-benefit ratio of anesthesia and surgery for the high-risk patients. If you know that you're going to need to send this patient to ICU for 1 to 2 weeks post-operatively, and they're going to need to be doing labs every single day, you may need to put them on meropenem and other very expensive drugs, and you know you're not going to get that. What's the point of risking a bed for other people? Because you really want to go and do a beautiful, fantastic surgery. So these are some of the things you have to be mindful. This concern should be conveyed to the patient. Honest of kin and documented. And sometimes, just discussing this with them, you see some of the money start flowing. So assessment and preparation. So I'm running up, okay? They told me my time is up. So the patients, so for the respiratory system, one of the things we'll do in the assessment is the assessment of the airway. And if you're unlucky to have a patient with a difficult airway on your table and you did not know it's a difficult airway, one of my very, 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 very good surgeons, he said to me, Chris, you know, I don't care how big the tumor is or how much the patient wants to bleed. There's no vessel I cannot clear, but the airway, please don't bring it to me. Immediately he's doing surgery and he's misbehaving. I said, hey, boss, you look like the tube is not in. All of a sudden, an air conditioner will start sweating. So airway, malampathic classification grade, we basically look at the ease of it. And then we basically let them open their mouth at the same eye level as us and stick out their tongue. And what we're just trying to see is how far we can see. Can we see the tonsils, the uvula, the cords, okay? If you can see as far as that, you have quite not a bad airway. But there are some of the patients you look and the only thing you can see is hard palate. You can't even see soft palate. And that is malampathy 4. If you have a malampathy 4 and you did not prepare for a difficult airway, vecuronium, and you cannot ventilate them, start singing Hallelujah chorus and start looking for where your license is. Because they may come for it. So for that reason, you're able to make available help as in personnel, can get for intubation. So we have a video laryngoscope. So in our neuro theater, it's almost always there, and then we have one in the general theater. So when you assess it, then you can get it closer. But with a video laryngoscope, you can see things that other people cannot see. Okay, for intubation or anesthesia, or providing a surgical airway. So there's some of these airways, we'll do fiber optic, or we ask the ENT to come and do a tracheostomy. We intubate, just do a tracheostomy on the local. and then we put our tube there and we put the patient to sleep. There's no point in going to give the person a hypoxic brain injury. Also, for pointers to difficult patient, because sometimes you may be seeing, but their larynx is in the skies, it's very anterior. The tube, for you to go there, you almost bending it. So, patient asthmatic or with obstructive airway disease, they are more likely to have post-operative pulmonary complications. They have a very reactive airway, so you need to have that information and have control there. Asthmatic, especially who have frequent attacks or who are on steroids or have been admitted in ICU within the last 6 months are at great risk. For these patients, don't look only at the airway, start looking at their hearts. These are patients who have bigger hearts because they've been getting all these obstructive effects. So ECG, chest X-ray, gas, you may have to do a pulmonary function testing. And some of them may have to start antibiotics even before and bronchodilate them. And for some of them, we'll plan them for ICU even before we go for surgery. Because we know we can't extubate them immediately. We need to gently get them off. Obstructive sleep apnea is one of the ones that we have been very bad at. So everybody who snores, so now it's part of our questionnaire. So we'll ask you, do you snore? Oh, you know. Oh, you know. Or if you snore, unless you are not, number one, unless you are not married, or you don't have anybody in your house.
Oh, they may be afraid to tell us.
Oh, please. Look, for your wife to be afraid to tell you that you snore, then you must be kakai. Oh, even if you don't know, if you are a proper snorer, after some time somebody will be looking for earplugs. All right, but we have taken that for granted. But you know the bigger problem, they're almost like obstructive sleep and this obstructive airway disease, but where still they have heart issues because they've been having these hypoxic episodes, so they end up basically developing bigger hearts and all this. And some of these patients, we have their 10 years time with them post-operatively because we knock off their hypoxic drive during anesthesia. And because we're giving them good oxygen rich, they need a little bit of their hypoxic drive to drive them. So we knock it off, they don't want to breathe again. And that includes children. So that's why when we are doing T&A, the tonsillitis and adenectomies, people think it's just a straightforward. A number of the kids we've lost in this capital are people doing tonsillectomies in private places without thinking about how long has this child has adenoids and tonsils. As it prolongs, they are basically obstructive sleep apnea. You take off that and the hypoxic drive to breathe is gone. You don't have a recovery ward and take them to the general ward. They go hypoxic and die. We've had quite a number of them being rushed to us. So they are hypertensives and are prone to hypoxia, hypercapnia, and dysrhythmias, and myocardial dysfunction. I'm talking about obstructive. Respiration is hypoxia driven. So if you take off their hypoxic drive and you're giving them oxygen rich, they will therefore become very lazy and refuse to breathe. So we tend to give them lower concentration of oxygen post-operatively for this patient. These are just some of the things we investigate them. Diabetics, remember that most people who have diabetic may have coronary problems, and when they have MI, it is silent, so they may never know that they have ischemic heart disease. So if you have a diabetic who's been diabetic for a while, that we are assessing for major surgery, it's important to take a good look at their hearts to be sure that they don't have problems. ECG, sometimes you need to do an echo. And of course, you want to know what their blood pressure is controlled, and that is not by fasting blood sugar. That is the calculated hemoglobin that will give you a duration of 3 months of their control. Some of them, because they know that they are not doing the right thing, the day before they come, they take a little bit of overdose of their medication. You do a fasting blood sugar, then they have 5.2. They say, hey, do their glycated hemoglobin and you see 10.5. Bleeding diastasis, some of them are congenital disorders of coagulation. Those patients, anticoagulant, they have bleeding problems. Some of them post-op, they will not stop bleeding. Unfortunately for you, if you have gone into a habit where it's difficult to stop the bleeding, you may bleed to death in here. important to involve the hematologist and make sure that some of this. Among other cases to be considered when you are thinking about patient preoperatively is morbid obesity, and we are becoming more obese as a country, not because our CD is appreciating, but because we are not eating very well or because we are eating late and not exercising. Okay, so morbid obesity is gradually becoming a problem to the fact that now it is used in the ASA classification. So BMI less than, more than 25 but less than 30, you automatically jump into ASA class 2. Yeah, if that is even the only thing you have, with no other reason, you are ASA class 2. If your BMI is more than 30 up to 35, you enter ASA class 3 because the complications are finished. Because the complications that are associated with it can be in every system. Okay? So also remember that now that we are doing a lot of cardiac interventions, there are patients who are walking about nicely, smiling, but with pacemakers in their hearts. And you could put them in theater and start something and their pacemaker battery goes off. Or they are close to equipment that interfere with their pacemaker and then it shuts down in your small theater in the districts. And then you're wondering, what have I done? Dialysis-dependent renal dysfunction patients, because the period that they are on admission, having their surgery and recovering for the surgery may mean that they may go up to 5 days without dialysis. But if they are dialysis dependent, these are patients who have dialysis every 2 or 3 days. So you need to take that into consideration. How do I deal with that? The main aim is to facilitate the anesthetic arrangement. That is the ones we give preoperative. Most of it is just to calm them down, so the sedatives, and then sometimes their own current medication that they are taking. We review them, the one that we need to continue, we do. So for example, oral hypoglycemic agents for major surgery, we will not take it on the day of the surgery. We may switch that to insulin. But for most of the antihypertensive, we will continue them. Okay, so even the instructions as to what medications to take are important. To end it up, consent. Consent forms is you're confirming the patient with the patient or guardian of the nature of the anesthetic procedure and the surgical procedure to obtain informed consent for both. So now we have a new. Okay, you load. Okay. We've changed our consent form in Kolebu because of this. Our old consent form, and I don't know if you are still using the old generic one from Ministry of Health, where it's basically I consent for such and such surgery with which may be complicated by bleeding disease, blah, 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 and then sign and then witness. No, we stopped. Because that does not go into detail, and people can sue now and say that you did not still give them a good enough information. So the fact that the person signed it is not good enough. And the old consent form does not consent for anesthesia or for blood transfusion. So now we have consent form that includes both, and we actually have an additional consent form for transfusion of blood products. Oh. That one. Yeah, it was done by Kolebu, but I don't know if other hospitals have adapted. What I keep saying is that there's no point in reinventing any new wheel. Our ICU protocol, which I basically developed, I basically carried the things from Edinburgh and then modified it to adapt to us. Nobody should be wasting time developing new things. You waste 2-3 years, and when you finish, they tell you that even the people who break it, they should come and tell that. So now what I basically do is, if I see something that can be adapted, we adapt it and use. Okay. Oh, sorry. All right. So when it's properly signed, both patient and provider safety is assured, and the quality of care is improved, because it means that even we are thinking through what we are writing and consenting them to. I have mentioned documentation earlier on that is very important, but it should be legible. Everybody should be able to read what you have written. Not the fact that you're writing something like this and because you are a neurosurgeon, we should all know that it's craniotomy. Okay. All that you say or do, including others, arrangements, and for post-operative ICU transfer must be documented for medical-legal reasons. They are suing. Now, it's no longer, some of our hospitals are not telling us how many they are basically settling, but they are suing. So, with that, I said thank you.